Hi guys, good evening. Dr. Jenny here, physical therapist and doctor of physical therapy, creator and founder of Balance and Fall Support Group in Aging Adults and geriatric physical therapist. So I am here today. Today is Thursday. Thanks God it's Thursday. Every Thursday, we highlight innovators. We interviewed academicians, physical therapists globally. We even have audiologists. We even have a speech pathologist, physical therapist, and innovator from Australia and London. So for tonight, we have academician, also a great leader. So if you want to learn more about residency, specialization, wanting to be in a leadership role in Academy of Physical Therapy Association, of course, we have Dr. Rick Beato. We call him Dr. B. He is a physical therapist, doctor of physical therapy. He's a dual certified. He is a board certified specialist in geriatrics and neuro. And he is now a board member of the American Board of PT Specialties. So in the American PT Specialties, they are the one in charge in having some votes. And then there are 10 specialties that they lead more on. They discuss about it. So we want to learn more. What are those things? And especially the residency. It's really important, especially if you want to learn more about your specialization, right? And he is also who served the past chair as the neurologic board specialty council, and also he was the past chair of the geriatric board specialty council. You're amazing, Dr. V. Oh my God.
Thanks,
You
Dr. Jenny, for having me in your show.
You are so amazing. I even don't finish. He even have lots of lectures in CSM, lots of research. We're just beginning, and then we almost maybe 20 minutes just telling all his. So
Dr. Jenny
welcome.
yours also amazing. Everyone's amazing.
Oh, thank you so much. Dr. B, thank you so much for your time. And also, I know you're very busy, and welcome to our podcast. How are you?
I'm good. Thank you. Thank you. It's been a busy day, with teaching and research and residency. And we just finished the residency admission process for the next cycle, and we still have our current residents. And so, and then, with the grants and research, submitting for grants, and yeah, it's been busy. But everyone's busy, right? You're busy, I'm busy, everyone's busy with their lives. But happy to be in your show.
Thank you so much. Yeah, you are associate professor in residency. That's why you talk about all the residency. You're a director in the University of Central Florida and director of PT in neurologic residency. So tell us more. This is really amazing. As a physical therapist, of course, you are being physical therapist for 2 decades. So can
Yeah,
you tell us a little bit first on how you transition in this academic what do you call this? Like you're
the
now a
role,
professor.
yes.
Yes, academic role. So as a clinician, did you work in home health or outpatient? Go ahead, Dr. B.
Oh yes, I do. I still see patients, right? So
Yes,
I
yes.
am a full-time faculty, but usually we have 9 months appointment in the academic setting. So during summer, right, we don't work full-time. We only work half of the time, depending on the load of the faculty. So I usually work around half of the time in the summer. So half of the time I'm still working in the skilled nursing facility because I love my geriatrics, right? I always come and see them during the summertime, especially about half of my caseload. I see them in the summer. So summer's coming, so I'm excited to see my patients in the nursing home, in the skilled nursing facility. But the main settings that I've worked with is geriatric and neurology. So skilled nursing facility, I work in outpatient, I work in home health. Not so much in acute. So that's probably the setting that I have the least experience, but the most experience is where geriatric and neurology meet. Um, Interesting question, like you said. How did I start from clinician going
Yes.
into the faculty position? So I always loved to teach, even when I was a student, getting in front, doing your reports and all that stuff, and then having guest lectured in a lot of classes. I found that I do like teaching, right? When I go to the university or to the state college or to the community college, and guest lecture in the PT program or in the PTA program, I find that I really like it a lot. And so I did take students from UCF, the University of Central Florida, which is the state university in Orlando where I work for. So I used to take students from them and also from the community college, usually like the Polk State College or the Seminole State College program, because they have a PTA program. And I find that I really, really enjoy having those students, teaching them as a clinical instructor. And so when there was an open position at the university where I currently work for, I did apply for that position. And it helps to have a board specialization because the position was requiring that you be a board specialized in neurology and geriatrics. And, lucky enough, I have the board specialty in both, and they wanted to start a residency program. And there's several applicants, but in the Orlando area, you also have to be able to connect with your community because, the university needs those connections in order for you to be able to establish a strong relationship between the university and the community partners. And UCF is classified by Carnegie as it's high intensive research. So it's an R1 research university, but it's also very high in community engagement. And so a requirement would be for you to be able to have great relationship with the hospital systems and the clinics and our community partners and the support groups. And I have that. So I felt like I had the advantage. And it also helped that I was the only board certified in neurology during that time in the Orlando area. So they're looking for someone to
Wow.
run the residency program. And so, I started as my role is a clinical faculty position. So there is patient care, there is the residency program, there is those expectations on top of research and teaching. So when, as a faculty, people always think that we just teach, but we also have research expectation because it is an R1 research institution. So there is a high expectation of research, but there's also for a clinical faculty, there's a clinical expectation. So in my area, it is the residency program. So it's like multiple jobs in
Yeah.
one job, but it's great because, like you were saying, there is an advantage because you get to do a lot of things, right? Different things. So you don't get bored. Definitely you won't get bored because you have so many things to do. But on the other side, on the flip side of the coin, the disadvantage is that you have so many, in a way, you have so many jobs to do instead of just doing like clinical or just doing teaching or just doing research. So you have, it's a disadvantage because now you have so many roles, but it also keeps you it keeps you on your feet all the time. So it does make me busy. And I like it, right? But
Yeah.
busy is not always, it's not always like glory and stuff because you have to do the responsibility of it.
Yeah, it's really amazing. Especially, I keep telling to all the people I interview, whenever they talk about research, I said, wow, this really complicated research. So what are the skills that we need? Before you enroll, what do you call enroll? Before you go to the faculty position, do you have like to study or did a certification for to be a teacher? Like to have a skill for that or to pass a certain exam just for the teaching part, knowing you're already a physical therapist and you
No,
have
you don't.
the
Yeah,
edge,
you,
is
you
what you
don't
have
have
said.
to. You don't have to,
Oh,
especially if you're applying for a clinical role. It depends though. When you have, because there's usually three types of faculty in our university. You have the instructor or lecturer track. You have the clinical faculty, which usually most of the healthcare professions like nursing, medicine, they
okay.
have a clinical faculty track, and then there's the research faculty track. So like in physics, right, in the College of Sciences, physics, mathematicians, chemists
Mhm.
chemistry, like they don't usually have the clinical faculty role. So you're either a researcher or you're fully instructor. Instructor means you're teaching the whole time, right? So you're
Oh,
teaching, you
okay.
load it. But the research faculty, you're teaching, but you're also half of your caseload is you're doing research. But for us, for clinical faculty, you have everything, right? So you get to teach, you get to your clinical role, and you also do research, but not as intensive. So the expectation is not as intensive. So
Oh,
no, there is no need for your viewers out there, especially when if you really like to teach and you find that you like
yes.
having students, there's always open positions for clinical faculty. It doesn't have to be a research faculty, right? Especially if you don't have a background in research, the clinical
Mhm.
faculty role is a great role, especially if you like seeing patients and having those patient interaction. You're not completely giving it up because, like you said, like in my role, there is a clinical portion, all right, right now I am the physical therapist in the interdisciplinary Huntington's clinic. So medicine is there,
Mm.
right? The physicians are there, the neurologist, the psychiatrist is there, we have social work, and it's interdisciplinary. But as a clinician going into the faculty role, as long as there is a clinical position, but if you like research, certainly, right? Usually it requires you to have a research degree going into the research track. But in a clinical faculty, they want your doctor of physical therapy, which is the requirement for every physical therapy program now, because you are going to be in a clinical track, right? You're going to supervise the students in their clinical care of the patients, or whether it's a residency program. So you don't have to, but once you get in, the university provides you with teaching certification, with teaching training, right? So we have that uh, at UCF, and most universities have that, right? They're not just going to throw you into the wolves. They're going to train you.
Mm.
Once you get hired, you're going to be trained on how to, do it in higher education, how to teach in higher education, in the pedagogy of teaching. So they don't just throw you into the wolves. They train you
Right.
before you go into the classroom. So it's a great question, because people think like, oh, do I just start teaching? No,
Yeah.
they'll train you well when you're there.
It's good to know because lots of our clinicians nowadays are learning more and wanted to learn more about the academician role, you know. And also, you're also resident director. So when we say residency, what are these and how does it work,
So
especially in your place? Mhm.
yes, no, no, no. I like that question, because when we think about board specialization, it requires us to have so many hours, right? Usually 2,000 direct patient care hours in order for you to board specialize in your area of expertise. And so sometimes some of the new grads, right, they do want to have hours and sit immediately for the certification, but you can't. You have to have 2,000 hours of direct patient care just for your specialty area. And it's kind of hard when you're a new grad, right? Let's say you just graduated
Okay.
from the program and you want to be a board certified. Well, then you have to have enough hours, and it has to be in your specialty area. You can't sit for sports specialty if all your patients were in neuro, right? And
Mhm.
on the other hand, you can't sit for neuro specialty if you're training athletes. Like that's just that's not gonna work. You know this, like you're board specialized in geriatrics. But the thing
Yes.
is, with a new grad, they want to be board certified. So one of the ways that they could do it to fast track is to attend a residency program. So every residency program is different. Could be, about 12 months. Some are 15 months. So 12 to 15 months. Usually it's just about a year. So most residencies are around a year, so 12 months. So you're still getting paid. I think the misconception of people is that the new grads, they think that residents are not paid, or they get paid too low. They're not. They're getting paid a pretty, they're getting paid an income, because they are a physical therapist. You have to be, you have to have your license before you go in a residency program. But the thing with the residency program is, you only, like, let's say, take as example for geriatrics.
Mhm.
You're going to go into the different settings for geriatrics and get all the patient cared hours that you need within 1 year, but you also have a mentor, right? Because every residency program you have to have a mentoring time. So it boils down to about 150 hours of direct patient care with your mentor, right? So, and then 100 of those hours, it has to be the resident who is the lead clinician treating the patient, right?
Okay.
So, it varies with every residency, but it averages about 3 hours. And in our residency program, our mentorship is even more than double the time, right? So it's not just 3 hours, it boils down to 7 hours in our residency program. But there is a requirement for every residency program that about 3 hours each, you have your own patient caseload, but your mentor will be with you for those 3 hours. So in case you have any questions. And then on top of that, there is the didactic curriculum, where you still have, you have to get your didactic hours, so that when you're treating a patient, let's say a spinal cord injury, then
Mhm.
you must have the didactic knowledge in order for you to be able to treat those patients. Like, what are the latest evidence on the exercise guideline for patients with spinal cord injury, right? What are the assessment that we need to use based off the evidence? So what I like about the residency program is, while you're seeing those patients clinically, you're also getting the didactic in order for you to to have the best knowledge in order to provide those patient care. So those are one of the advantages of the residency program. We do see, though, we do see applicants, and we have had residents, and most residency programs have had residents where they work for 1 to 2 years before they go to the residency program because they feel that they want to be a general physical therapist first and realize like, okay, this is what I want, so I'm going back to the residency program. So it doesn't have to be new grad. Does that make sense, Jenny? Like,
Yes, yes.
that you can be a practicing PT and go back to the residency program. The only disadvantage I see on that one is that it's harder for someone to have like, let's say, a higher salary, and then you're going to residency, which is a little bit lower. It's not much lower, but it's a
Mhm.
little bit lower because you are being trained in a residency program. So very similar to medicine. It gets paid a little bit lower, but not by much. You're still getting a salary. I think that's one of the misconceptions of people.
Okay, good to know because maybe there will be hiring that residency program. So we really need to know that this is more on a training and you need to focus on neuro because that's a residency program. So it's
Yeah.
not a generalist. And
Yes, I'm
that's
glad. I'm
really
glad we
good.
clarified that in your show, right? So people would
Yes.
know that you are you have a job. You're hired as a physical therapist,
Yeah.
except that you're being trained in such a one specialty area of physical therapy.
That's true. So you're not going to treat ortho and especially hip fracture and everything. Then you will have stroke later on the other day. Especially they will be more on the acute. This is more in the subacute setting too. Yeah.
Exactly.
So
It's
how
true.
about Doc? Thank you so much because you congratulations as a board member of American Board of PT Specialties. Now, when we say specialties, these are the board certified specialties in geriatrics, neuro, so what will be the tips? What are the updates now? We have many clinicians listening right now and they want to learn more. They want to be specialized. I know June and July will be the time to enroll. So tell us more about it, Dr. B.
Oh yes, thank you, Dr. Jenny. As a board certified geriatrics, you know this. As one of the
July, I
best
think.
board certified geriatrics in the country, Dr. Jenny knows about this.
Oh, thank you, Dr. B.
But for her viewers, we would clarify, yes, she is right, absolutely right. So around July is the deadline to apply for the board specialty areas. They can extend it sometimes to September if there is some
Ah.
circumstances where you didn't make it to July. So yes, but the application process usually is around July, and it's some people will get extended, but you will have to pay an extra fee if you're late, right? If you decide you want to
Okay.
submit in September. So you want to submit in July for the 10 board specialty areas of physical therapy for the viewers who wanted to specialize in one of those 10 areas. Of course, we have the big ones. We have orthopedics, which is the biggest specialty area, and then we have neurology, and we have sports, geriatrics, and pediatrics, and then we also have cardiopulmonary physical therapy, clinical electrophysiology, and then we have women's health board specialty area. So remember, it's not pelvic health, even though the academy is pelvic health. The board specialization is women's health physical therapy, and of course, we also have wound care physical therapy as well
Mhm.
as oncology. So oncology and women's health oncology and wound care are the newest board specialty areas of physical therapy, wound care, right? So, for those of you who are interested, know that it is July, and then you will, once you are approved, if you are approved, most people will be approved as long as your hours are in your specialty area. You would have to take the exam, and that exam window, it's usually given at the end of February and the beginning of March. So from the time that you apply, you have until February or March, and then you get to select the dates if it's available in your city to sit for the board specialty examination. So I think one of the things that people tend to miss is that they think that for you to be a board
Mm.
specialty that you have to have all those residency hours. You don't have to be a resident in order to sit for the board specialization. As
Yeah.
long as you get the 2000 hours in the,
Yes.
in most recent years, as long as it is in your specialty area, you can have your own
Mhm.
training. Like let's say for geriatrics, you can
Yeah.
always go to certified exercise, the CEAA course, certified
Yes.
exercise expert for the aging adult, right? That's a good
Yes.
review to sit for the board's specialty examination, right? And the neurology section has courses. If you go to the APTA website, if you don't decide to go to a residency and you take the clinician, the no regular hours route, you can always go to the APTA website in the APTA Learning Center. When you take those courses, there are courses that are approved exactly for that specialty area. It will indicate on those the APTA courses.
Yeah, and that's how my route is. I did my certification in exercise expert aging. While
Mm.
reviewing, I have a seatmate. Oh, it's July soon. Why don't you just try to enroll for the GCS? Because this is a review for you. And I'm doing my doctorate that time. I said, okay, let's do it one in time in passing. And then
Yeah.
it overlaps all the review and reading materials. So that's really a good thing to know. Yeah.
Yes. And so for those for your viewers that think that is this for me? Yes, it is for you,
Mhm.
especially if you're specializing in an area of physical therapy. A lot of people think that it is about the end, which it is, right? Because they wanted to be board certified. They want it in their name.
Yes.
The
Yes.
GCS, the
Mhm.
NCS, the OCS, the SCS, the PCS. Yes. Yes, it is. But what I realize is that it is not so much about the destination, which is getting the board specialty. It is more about the journey, right? Being a better therapist, knowing what is the most current evidence in each of your patient condition, right? Knowing how to deal with your patient and give them the best care that you want. So, for me, it is more about the journey than the destination. Certainly, it was the destination when I was a younger therapist. I
Yeah.
want to be board certified. What do you think, Dr. Jenny? What do you think?
Yeah, for me, it's more on I always want to invest in myself, Dr. B, because that really mirrors whatever I'm doing to my clients and my patients. They really know
Yes.
if they're really receiving the best care. Oh, this is something new. I'd never do this before, you know? That's why I keep progressing every time I do. There's a certification, I grab it. There's a new knowledge, there's a new courses that I'm interested, I grab it. And then because I keep adding more skills because I want to have lots of skills in my toolbox, so we call it. That way it's not the cajon treatment. It's us what you've said, evidence-based, and our patients really will benefit. And it bounce back on you. It's really a good opportunity that you're really now we're having more on leadership skills, but as a clinician, you really need to really invest because that's really your skills that you need to be proud of, you know, and these are patients really will benefit. And that's your goal. You're passionate as a physical therapist, be the best of what you can be, right? And these are
I
one of
totally
the
agree with you.
tools.
I totally
Yeah.
agree with Dr. Jenny, and that's actually how we met because we were both board certified in geriatrics.
In APTA. So we really want you guys just to be around wonderful and great people. That way you will have them as a mentor, go with APTA, check what are the benefits, Dr. B, of being a member of APTA, knowing that you are now a board member of ABPTS and last you're certified in clinician geriatrics and neuro. So
Yes, no.
for us, for our listeners.
Oh yes, one of the benefits of I would say one of the main benefits of being a member of the American Physical Therapy Association is the evidence, your access to evidence. Because now, as Dr. Jenny was saying, most of the practice of physical therapy is based off the evidence, right? But the APTA provides you the new clinical practice guidelines for each of the patient's condition. What are the new assessment tools, the EDGE, the evidence database guide to effectiveness, right? We know, like I can talk about the neuro section, right? When you are assessing a patient, what are, the tools or the outcome measures that have been proven to really is valid for the patient and has been, for that specific patient condition, like let's say stroke, vestibular.
Mhm.
There's certain outcome measures that the evidence, the research has shown that these are the most valid and reliable for your patients. But now APTA is pushing for the clinical practice guidelines, right? Like when you think about the orthopedic conditions, right? You think about fracture, you think about the joint replacements. We now have the clinical practice guidelines, right? In neurology, we have for vestibular hypofunction. We have so many,
Mhm,
right? We have for
mhm.
Parkinson's, right? When we're treating our patient, we know that physical therapy works. But when you have the clinical practice guideline, as it has been vetted by the experts of the APTA based off the highest evidence. When you look at those randomized control trials, we know that these exercise interventions are effective. And how do we know they are effective? Who creates this clinical practice guidelines? It's the experts, looking through those research. So that way we don't have to read every single
Okay.
study, right? Like as
Okay.
as a clinician, we just look like, oh,
Summarize.
okay, right. We know that aerobic capacity, right, is great for patients with Parkinson's, or we want the patient to be able to walk. Then we look at the locomotion for clinical practice guideline, right? We looked at treadmill training as well as overground training is great for our patient. But then we look at like as a geriatric clinical specialists, we think about, well, what about our older adults? They kind of don't want to walk a lot on the treadmill. Well, then we look at the clinical practice guideline. It says that, the recumbent bike as well as the stepper, like the new step, old people like new step.
Yes,
That
yes.
may, right? That doesn't mean that necessarily like should, like the treadmill, but it may improve walking. And so we know that in the clinical practice guideline that it might work. And if that's what your patient wants, go for it as long as the clinical practice guideline is saying that research has shown that it is effective. So the APTA for me is a source of those evidence. And if it wasn't for the APTA, like we wouldn't know. I would have to read every single study in those hundreds and hundreds of studies, but they digest it for you. Like here's your access to the clinical evidence. It's amazing to have these tools because when I remember graduating from physical therapy school, we didn't have this tool. We have to look at the study, each one of them, right? But now somebody else looked it for you. The APTA looked it for you, right? They got those experts and they look at those research, the high quality of research. Because I think, Jenny, one of the misconception, I see this on a young student, right? When we haven't trained the students yet, we ask them like, okay, what is the evidence for your intervention? Then they're going to look at the intervention. They're going to pull a study, and it's okay, right? When you pull a study, you read a study. Oh, I'm going to do this with a patient, but you have to think, what is the level of the evidence? If it's the lowest level of evidence, right? Like if it's an expert opinion, it wasn't a study, right? Or the low level of study, you can't make a conclusion because one patient received it, or even five patients received it and they improved. That doesn't conclude that, oh, okay, this is effective for the patient. You have to have a well-designed, randomized control trials, and it has to be so many randomized control trials to say, okay, this is effective before we say an intervention is effective, right? Like we have to be able to synthesize those evidence. We can't just because somebody said in a class or somebody said in a continuing education course that it's effective, right? Or like one study with one patient or two patients said it's effective. That doesn't mean it's effective, right? But the APTA makes it easier for us as a clinician. They vetted the people who are going to look at those evidence. They vetted the research and they synthesized and, simplified it for us. Like here, it is effective. Nope, that's not effective. Here, may be effective, right? And so it makes it easier, the lives of the clinician. So that's certainly one of the best aspects in the APTA. Plus, you get to network with great therapists like Jenny. That's how I met her through the APTA. Some of my best friends are from the APTA, right? I
Yeah.
really think that, it's worth your membership. I think that some of the networking and
Networking, yeah.
right and forward, like, progressing in your career, if it wasn't for the American Physical Therapy Association, I wouldn't have taken the path where I'm very happy that, I mean, I'll still be happy without the APTA, but I feel like there's more fulfillment because I get to network with these individuals, amazing individuals like Dr. Jenny and everybody else in the APTA.
Yes.
So
Thank
it
you.
gives you more access to those people.
Yes, thank you so much, Dr. B. I really last CSM I met lots of everybody in person, I'm really excited. And as what you've said, lots of benefits, and they even have different sections,
Oh,
different
yes.
special interest groups in different sections. Whatever your interest, whatever your passion, is it ortho for me, manual therapy, or just like I want to do more on wound care, as what you've just talked about. Is it more on stroke and neuro, or it's just like you have the choice and everything is there for you. So just check, connect, and then you will learn more. All right?
Yeah, no, no, no. I'm
Yeah.
glad you hammered that point that you're going to see the people that have the same interest as you are, right? Like it's hard. Like when you're a neurotherapist and you're friends with ortho, right? Like when they talk about manual therapy and you're talking about locomotion clinical practice guideline, you're like you're getting bored with each other sometimes, right? Talking or like they don't understand what you're trying to tell them
Yeah.
because they have a different patient population. But when you go to the APTA, right? Like let's say you have a very specific area, let's say vestibular, right? So
Mhm.
you're going to talk to people who see vestibular patients like you do, and they know the evidence. So
Yeah.
it's just different, right? Not to say that, not to say that if I talk to my colleagues of a different specialty area, they wouldn't know what I'm talking about. But the people who are in your specialty and subspecialty will
Yeah.
actually understand you more. It's the right,
Yeah.
the conversations are more deeper.
Deeper. Yes, it's
So the
deeper.
conversations are deeper.
And they can challenge each other, share their experiences with the specific cases. And another thing we talk about, these are more very beneficial for our clinicians. But how about our listeners, Dr. B? This is my last question. Any tips for our listeners regarding fall prevention, improving their balance, knowing you are a neuro, you did some in CSM, talk about the brain. So talk about us give us some tips to improve our balance and prevent falls, Dr. B.
Oh yeah, especially for older adults, right? One of the best things
Mm.
when I was when I became a board certified geriatric clinical specialist, as as you were trained to look at the evidence, I think if there is one, right? I mean, there's so many evidence and different types of intervention, but as an older adult physical therapist,
Mhm.
I would say that the one that helped me the most is the compendium of the Center for Disease Control. So the CDC has this compendium of fall interventions for older adults.
Mm.
And so, how do we get there? Like, if you go to Google, you just type CDC Compendium of Fall Interventions. And what is this Compendium of Fall Interventions? It is a collection of the most recent fall interventions with the best evidence that truly they are effective in our older adults. It's very specific to older adults, right? That means we can't use these interventions for young children. We can't use this for middle-aged individuals, but it is for older adults. And because the CDC, the experts of the CDC have looked at the evidence and have made sure that these are high quality evidence that these truly, truly are effective in older adults. And so exercises like the Otago exercise program,
Yes.
which came from, right, from Australia in the area of Oceania,
Mm-hmm.
right, New Zealand, in
Mm-hmm.
that area where a lot of the individuals are have been using Otago, right? I found it through the compendium of the
Mm-hmm.
CDC. So they have multiple interventions and the type of exercises and the research studies are referenced in the CDC. So if there is one thing that I would recommend and highly recommend to your viewers, like for older adults, go to the CDC's website and look for the compendium, right? Just type in Google, it will actually pull you. It actually just came out with the latest edition, right? So the new research on what type of interventions are effective for your patients, it tells
Mm-hmm.
you there what kind of setting, what it is, right? Like, so check it out. I think
Yeah.
I've used it based on my experience and based on research. We use the compendium. Like, for those of you who are not aware of the compendium, just go to the CDC. It lists every intervention that is effective and has been looked at for older adults. And it's free. That's the best part.
Yeah. Thank you so much, Dr. V. Lots of tips there. So if ever you have question, guys, if you want to have a mentor knowing more about residency and specializations, connect with Dr. V. How can we connect with you, Dr. A?
Oh, yes. You can email me at my first name, Morris, Morris, dot, last name, Beato, B as in boy, Eato for yeah, it's or you can Beato. It depends
Yeah,
on how
I
you
thought
pronounce it,
Beato.
right? So Morris dot it is Beato, Morris dot
Ah,
Beato, but a
okay.
lot of my students like Beato, Morris dot Beato at UCF.edu. UCF stands for the University of Central Florida. So,
Mhm.
and it is in Orlando, from where Mickey Mouse lives.
Disney. Thank you
Uh,
so much, Dr. B. These are amazing. We learned lots of things from you, and you are amazing. You're a professor, clinician, and definitely congratulations in all these kinds of leadership and your service. We appreciate you.
Thank you, Dr. Jenny, and everybody appreciates you. Thank you for having me in your show, and we appreciate you too. Everybody appreciates you.
Thank
Thanks.
you. It's so nice to see you in the CSM. So, guys, if you want to learn more, connect with great people like Dr. B, great leaders and clinician. We really need to invest in ourselves, learn more, study. We have lots of evidence-based resources out there. And we always talk about you are the five people around you. So just look around. Who are the people around you? So connect with them, right?
There you
Yeah.
are, Jen, my screen.
So check because they really influence you a lot. So like me, I want to learn more about research. I will look for different videos. I have Dr. Amy, Dr. RV, now I have Dr. B. They do lots of research and I will learn more about that because I don't know too much about that. And they will say, oh, these are the proposal, these are the white paper, things like that. So if you have any questions, connect with Dr. B. And thank you so much for listening with us. And to all my Muslim friends, Ramadan Kareem. And then we're beginning now the month of Ramadan. If you have any questions, you want your certifications, you want your specializations, July is coming up, be a member and you will have more discounts with different courses. All right? With the
Yes.
APTA.
Oh,
All right.
also, before we leave, I want
Yes.
to let the viewers know, for those of you who are not aware, right,
Mm,
that there is a mentoring program in the Academy of Geriatric Physical Therapy and the Academy of Neurologic Physical Therapy, right? If you just go into their website and you're looking for a mentor in your
yeah.
area, There is, they have a list of mentors, especially in neuro, they have a list. But in Jerry, just reach out to the chair of the GCS committee, and they will partner you with a mentor in your area that can help you prepare for the specialization process. So know that those resources are out there.
Yes, so that it will be easy for you to
Yes.
review. You have a roadmap to pass your exam, all right?
And that you're not on your own.
Yes, yes, you have a group, you have a study habits, you have a partner or even a group. So to learn more, what's best for you, what works for you, what's your resources, things that there, right?
Yes, that is
Okay.
absolutely right. So thanks,
Thank
Jen, Dr.
you. You're
Jenny, for having me.
welcome. Thank you, Dr. B. And thank you so much, guys. And good night. It's me again, Dr. Jenny Yusuf, physical therapist and doctor of physical therapist, creator and founder of Balance and Fall Support Group, and your state advocate in Delaware for the APTA geriatrics. All right. Bye for now, guys. Thank you. Thanks,
Bye,
Dr.
everyone.
B.